This lecture is about lung cancer. You're going to have to do three things. The first is to recognize who has lung cancer and find the way to make the diagnosis. The second thing is to recognize someone with a solitary pulmonary nodule and then know whether or not you can just follow it or if you have to do something about it. And thirdly, we will review the different types of lung cancers and sort of how you spot them and what brings them on. Let's start off with the person who obviously has a lung cancer. This is going to be the person who presents with fever, weight loss, and hemoptysis. Now this could prompt you to think TB, and you'd be right. But when they give you a long history, old guy, smoking history, and this, they're driving you down towards the lung cancer route. And the first thing you do when you see this is to get a chest x-ray. And the chest x-ray can show you one of three things. It could show you nothing. And then you question, why are they having hemoptysis? It could show you an effusion, in which case you have an effusion. Or it could very clearly show you cancer, and then you've got lung cancer. That is, it shows you a mass. But just because you don't see the lung cancer on the chest x-ray does not mean they don't have lung cancer. Chest x-ray is actually a really terrible screening tool. In this case, we got it because we wanted to evaluate the hemoptysis, not because we're looking for a lung cancer. So if you find something else other than lung cancer and you're thinking it's lung cancer, you might still go to the next step. In the case of nothing, you have to ask yourself, is there a paraneoplastic syndrome? That is, what is the chance that this person has lung cancer, even though the chest x-ray is negative? If they have a paraneoplastic syndrome and their chest x-ray is negative, consider them to have lung cancer. If the chest x-ray is negative and they have no syndromes, then it's not lung cancer and you can stop. Now, if they have an effusion, you're not going to stop with the effusion. As you'll learn in the pleural effusion lecture, what you want to do is go ahead and tap it. That is, do a thoracentesis. And if in the fluid you see malignant cells, you've got lung cancer, or you have a metastasis. And the type of cells you find in the thoracentesis will give you the answer. But if all you found was an effusion and there's no malignant cells, it's not lung cancer, and you can stop. Chances are you're now in the pleural effusion lecture trying to figure out what caused the pleural effusion. And the idea here is that an effusion may hide the mass. The chest x-ray is not a very sensitive test. And so, if you suspect lung cancer, what you want to do is localize the cancer using a CT scan. And then you're going to do two things at the same time. Let's talk about different biopsy modalities. These are a set of lungs. If the cancer is here in the large airways, part of the bronchus or the trachea, you can imagine that you could pass a rigid tube into here pretty easily and just see it. You literally look down the tube, there it is, take a piece. That is called bronchoscopy. If the lesion or the lymph node that's suspicious is on the other side, that is not the side of the lumen you can see, you can still do a bronch, especially if it's in these larger airways. But instead, what you want to do is the newer way of doing this procedure called EBUS, endobronchial ultrasound. With a camera, the bronch, you can't see through the wall of the trachea. With the ultrasound, you can. You get a better localization of the thing on the other side to make sure you actually grab a piece of it. It's basically doing a bronchoscopy, except you have an ultrasound to see through the wall to make sure you're grabbing a piece of the thing you want to grab a piece of, as opposed to just randomly poking blind. So large proximal lesions, bronch or EBUS. If the lesion's way out here in the periphery, since the caliber of the airways gets smaller and smaller, there's no way to reach that far with a rigid bronch. But you can pass a CT-guided percutaneous biopsy from the outside and grab a piece of it. This will be biopsy with CT-guided percutaneous biopsy, a needle biopsy. But if the lesion's in the middle of the lung, CT needle biopsy can't get there without going through lung. The bronch can't get there because it's too far in the middle. This is the time where you need to call your cardiovascular surgeons for them to do a video-assisted thoracoscopic surgery. You're not cracking the chest, you're not necessarily resecting any lung, but you get in there and take a piece of the cancer. As we talked about up here, you can actually diagnose somebody when there's a pleural effusion rather than a mass. If you do a thoracentesis and it's positive, you have stage 4. It is metastatic disease. And there is this case where you can have this nasty, big, gnarly lesion in a high-risk patient, spiculated mass, smoker, old, where you know it's lung cancer. That person can actually be diagnosed with resection. And here's the thing. These are the different ways of making the diagnosis, of getting a piece of tissue, of biopsying it and confirming you have lung cancer. But the way you really work up lung cancer is to first stage it. And generally that's going to be done with a PET. But PET CT should only be done when you have confirmed cancer. Well, that's frustrating. What the hell are you talking about? Either make the biopsy first or get the staging. Well, there's going to be somewhere that you read or that you hear about that in lung cancer, you don't want to go putting needles in the lung if you don't have to. The idea here is that you make the diagnosis and the stage at the same time wherever possible. This is relevant in the case of someone who has a lung mass and then has axillary lymphadenopathy. Biopsy the lymph nodes. If you find lung cancer, you don't have to go into the lung and you've already staged it. If you've gotten the biopsy this way, you know it's lung cancer and now you want to stage, use the PET CT. The second thing to do is to get PFTs, because chances are you are going to do surgery. Lung cancer is generally treated with surgical resection, chemo, and radiation. We'll talk more about that at the end for the individual cancers. But you can't go cutting out a lung if they can't handle it. And since they generally were smokers, they may not be able to tolerate resection. So do the PFTs first. And then, and only then, after you made the diagnosis, staged them, got the PFTs, then you treat them either with chemo, radiation, or surgery. The bulk of this talk was to get you to understand how you make the diagnosis, and then that you stage and PFTs before you begin treatment. And also that just because your chest x-ray doesn't show you a mass does not mean you don't have lung cancer. Okay, now let's talk about the person who does not obviously have lung cancer. They've got a pulmonary nodule. Lung cancer is primarily about smoking. So I want to talk to you a little bit about primary prevention and screening. Because lung cancer and smoking are so tightly correlated, primary prevention is about smoking. Either smoking in yourself, that is never starting, avoiding secondhand smoke, and if you do smoke, cessation. These are the things that are going to reduce your risk of lung cancer. If you smoke right now, quit, you will reduce your chance of lung cancer. And as we just talked about, the chest x-ray is a pretty crappy test. So people tried to screen people with a chest x-ray. Don't do that. That's wrong. What we know now is that what we should be doing is using low-dose CT scans. We do that every year. So who needs the low-dose CT scan screening for lung cancer? It is going to be the person who is between the age of 55 and 80, who has a 30 pack year history, and who quit smoking less than 15 years ago. That is to say, they quit right now They have to get an annual screening CT scan for 15 years, and then they're done. When you get that screening CT, you're going to find nodules. Lots of people have nodules. Not many people have lung cancer. So now you're left with the decision of, what do I do when I find a nodule? There are certain characteristics of the nodule itself and the person that kind of give you an idea of whether this is cancer or not. So you want to look at the size, the surface, the presence of smoking in the patient, and the patient's self. That is their age. Put that S in there because it's 4 S's. Size, surface, smoking, and self. The things that are good that suggest that this is not cancer are going to be a size less than 8 millimeters, the surface that is smooth, no smoking history, and age less than 45. Almost all lung cancers occur in an older population who have smoked. There are other risk factors like certain environmental exposures and as asbestosis, as we'll talk about later, and some chemicals and heavy metals that increase your risk, but you should be looking for smoking. So small, smooth, non-smoker, young, generally going to be not cancer. The other beneficial thing is calcified. The thing that says, okay, this could be cancer and is more likely to be so, it's going to be something that's greater than 2 centimeters with a spiculated surface, a history of smoking, and greater than the age of 70. Likely, if you found this, you'd go right to biopsy. If you found this, you don't really have to worry about it. But these are the characteristics of a nodule which make you more or less suspicious that it's cancer. So when you find a nodule, and you're going to find a nodule, you're going to have to decide what to do with it. This is where the test loves to go. If you find a pulmonary nodule, look at old films. Because if there has been no change in size for 2 years, it is said to be stable. And a stable nodule, no matter how big it is, you do not need to do anything more for. Either you were following this person with serial films on purpose, or they happen to have an old film that you can compare to the one you have now, no change in 2 years, not cancer, don't follow it anymore. But chances are it's going to be new or changing. This is said to be an unstable nodule. In unstable nodules, you need to decide, what are you going to do? We talked a little bit about the risk here. In an unstable nodule, what you have to do is compare the risk of the patient and the nodule itself and determine, is this likely to be cancer or not? Very vague. So here's the deal. If the person has lots of low risk, you're going to do serial CTs. If the person is high risk, you're going to do a biopsy. Now, if you go to any thoracic journal, it's way more complicated than that. But where I want you to get to is low risk serial CT, high risk biopsy, knowing that in here are other things that the nodule could be, like an infectious etiology, fungal, bacterial, mycoplasma, granulomatous disease. There is a wild card, but I don't want you to pay attention to it. So long as you can identify who's high risk, who's low risk, and get the old film first, you'll know how to handle the pulmonary nodule. Now I want to finish up with the different types of lung cancers that there are. Now we're going to compare the type of cancer with the pathogenesis or the risk factors, where it's located, generally speaking, in the lung, any paraneoplastic syndrome that might occur with it, and then the treatment. One of the big things you're going to do in the management of lung cancer is decide the difference between small cell and not small cell, non-small cell lung cancer. And the reason why I make this difference is because small cell lung cancer is exquisitely sensitive to radiation and chemotherapy, whereas non-small cell lung cancer, traditional cancer, you can give it, but after it's spread, you're screwed. So small cell has the pathogenesis of smoking. And because as you inhale cigarette smoke, the area that's going to get the most exposure to cigarette smoke is the trachea and the bronchus, it is going to be centrally located. Small cell lung cancer has two paraneoplastic syndromes. It is either going to be ACTH, that is Cushing's, or syndrome of inappropriate ADH. And the treatment is chemo and radiation. Contained radiation, distant chemo and radiation. All the other cancers are going to be treated with surgical resection, chemo, radiation combinations based on how advanced the stage is. Stage 4 small cell, treat it, you can put them into remission. Squamous cell, also caused by smoking, and for the same reason will be centrally located. What's the difference between these two then? Small cell is called small cell because the cells themselves are small and the lesion is typically small, but it is often metastasized by the time you find it, which is okay because it's sensitive to chemo and radiation. Squamous cell is generally locally growing and gets really big. Most lung cancers are advanced stage by the time you feel them because there's no pain receptors in the lung. So squamous cell is also smoking and centrally located and has the paraneoplastic syndrome of parathyroid hormone-related peptide. So look for the hypercalcemia. There's more on this in the renal lectures. Adenocarcinoma is the cancer that non-smokers get because they have been exposed to asbestosis. Now we talk about this in the interstitial lung disease lectures. Asbestosis has an association with mesothelioma, but also adenocarcinoma. Having asbestosis increases your risk of squamous cell carcinoma, and smoking with asbestosis increases your risk of adenocarcinoma. But for your test, adenocarcinoma is the cancer that people who don't smoke get. They have some other exposure. Adenocarcinoma, asbestosis, this is peripheral and so can present with a puckering or pain because it involves the pleura. See all those P's. It has no paraneoplastic syndrome. The last one you want to know about is carcinoid. Doesn't really have a pathogenesis. It's serotonin related. And it's located, can be anywhere. The thing you want to know though is the serotonin syndrome. And it is different than the carcinoid tumor you find in the intestines. The intestines metastasize to the liver and then produce serotonin. They cause a right-sided valvular fibrosis, flushing, wheezing, and diarrhea. The lung breaks down the serotonin, so the left side is usually spared. But in lung carcinoid, it begins in the lung. So there's no time, there's no metabolism of that serotonin. So what happens is the left side gets fibrosed. Left side of fibrosis, flushing, wheezing, diarrhea, serotonin syndrome, that's going to be carcinoid tumor. And the thing you want to do, this isn't the treatment, but the thing that the test likes to ask about is the 5-HIAA in the urine, which is a great question because it's a lung cancer. Why would you check a urine for a lung cancer? If you see the serotonin syndrome, grab the 5-HIAA in the urine. And then these two cancers that were left for treatment, it's stage dependent. You're going to give chemo, radiation, and resection depending on how advanced the tumor is. All right, so in this lecture we talked about the person who actually has a lung cancer, how do you diagnose them, and how do you work them up. the pulmonary nodule and screening for lung cancer and what constitutes high risk and low risk. And then we're talking about the different types of lung cancers, recognizing them either by their location or by their paraneoplastic syndrome. And that is lung cancer.